Hello, everyone. It's such a pleasure and an honor to be here with all of you. Finally meeting people who I've emailed and putting names with faces is wonderful. So bear with me. I have been asked to speak about type 1. Many have asked me to talk more about what we do in our center. So many things that I do when I speak with our patients, I see them one-on-one. I'm very lucky. I only have GSD. Big difference that many of you have many other metabolic diseases. So I can really focus, and when I speak with our patients, I really dedicate my time and energy to find what will work for that particular patient. So my objectives were to identify the different dietary guidelines and/or sugar restrictions associated with type 1 of GSD discussed. Explain the rationale of the current nutritional managements associated with type 1 of GSD discussed, and apply knowledge of nutritional management of GSD to prevent metabolic complications and nutritional deficiencies to promote appropriate weight gain, growth, and optimize the patient's nutritional status. So our type 1 dietary restrictions, of course, is sugar restrictions. Non-glucose sugars cannot be converted back to glucose. Fructose, sucrose, and galactose are limited in the diet, which means fruits, dairy, and sugary foods should be limited. 2.5 grams of fructose plus galactose per meal. I tell my patients less than 5 grams of sugars per meal, which includes the starches and carbs. The reason why I only say the sugars is because when you start going into fructose and where am I getting the 2.5 versus the 5, it's totally confusing. So I really try to be extremely basic with them. Actually, has anyone seen those numbers in any kind of write-up? Any evidence-based? Is that a no? You're correct. It's not. And actually, we and the Netherlands are actually working on a paper to actually show why we feel that these numbers are correct. So our sugar restrictions, lack of consensus among countries, different treatment, different strategies. For the US, England, and Germany, very different. So our commonly used formulas in GSD type 1 in infants, we use the Prosobi, which is a soy-based. We also use Tolerex, and especially for sick days. And if malabsorption or intolerance, a more specialized formula may be needed, which is Nutramigen, Vivanex, and Elecare. There is something fairly new on the market, and I did not put it on my slide, is Infogro Soy Toddler. I still have many patients that are 5-6-year-olds, and they still like the Prosobi to take with their cornstarch. And we're trying to transform them over to the Infogro Soy because the ratios of the protein and the carbs and the fats are different. And it's more age appropriate. So for sick days, we use Tolerex. For feeding aversions are very common. For the ones that usually have G-tubes, we recommend the feeding therapy team introduce solids to 6 to 9 months. If solids are not introduced, you are going to start getting a feeding aversion. And they have poor appetite. So actually, many of you are on the listserv for the metabolic dietitians, and I saw some questions regarding, can I please talk a little about feeding aversions? So the suggestions that we have, is that always feed them before you give them cornstarch. They're not going to eat. They're not going to be hungry. Watch how they chew. Do they chew in the front or in the back? So think about yourself taking a bite of a carrot. You bite in the front and you move it to the back and you mash it. When you have feeding aversions, and actually a speech therapist is the one that taught me this, is that they get very tired chewing in the front because they are not smashing it. And then they have to take this big swallow because it's still chunky. They get tired of eating. Food needs to be moist. So think of an infant. You go from liquid to baby food that's totally liquefied. And then you go to stage 3, which is chunkier. And then all of a sudden now you can start giving them the adult food. When it's feeding aversions, start slow. If you try to give them straight rice, it's dry, they're not going to want it. It gets stuck. Make it very wet for them. They also have a tendency of spicy, salty, and sour. Around 9 months, 10 months, when you're starting the vegetables and things, start putting spices on it. You're going to see that you're going to have much better luck. Start with small amount of foods. What we've also found is that some parents have a tendency to give them the same size plate as the adult and almost the same amount of food. And if a child has a feeding aversion, they just look at that, they're going to walk away or close their mouth. Am I right? So do a small plate, do one food. Let them try that one food. You'll see you'll have success. This week we had several children with G-tubes, and they used to have feeding aversions. So actually yesterday morning I had a young man, and he's like around 4 years old, and I come in with this tote with like 3 different bags. I have all my goodies in here. And I always try to make it fun for them. So I asked them, do you like to do experiments? And he looks at me and looks at Mom, and she goes, he does. I go, are you ready to do some experiments? Yes. The mom earlier spoke with me and said, he won't touch anything new. Can't get him to try anything. Very poor eater. So this is what I did. Does anyone give yogurt to type 1s? There is a specific type that we have here in the U.S., and it's called Dannon Light and Fit Carb Friendly. The sugars are 2 grams per 4 ounces. We're under the 5 grams, so we could have it. So I always have a yogurt, and I have what we call the Mio liquids to make it different colors. So I always get the vanilla because it's not a harsh, strong flavor, and most of your type 1s like vanilla flavored. And we start playing with colors. When the mom saw me, this child has never tried yogurt ever. And it's a texture. Yogurt is a hard texture and get used to. I always ask them to start small. So I go, just use your pinky. Your pinky is your smallest amount. So he did the pinky, and he kind of liked it. So we went from vanilla to I have him, and I put the Mio liquids, all the different colors in a row. So I have him pick out, what color do you want? He went for red. So he tried the fruit punch. We mixed it. I made him do the mixing, by the way. I didn't do it. He had to serve himself, mix it. Now he's an owner of that. I want him to want to try it. So he went from a pinky to a teaspoon. From a teaspoon, he ended up taking, well, a lick of a teaspoon, went to actually opening his mouth. To me, that was amazing. So after I saw that was successful, I also take granola. There's a granola that we use that only has 3 grams per serving of sugar, and he tried that, and Mom couldn't believe it because now that is a big texture because it's small, and sometimes they don't like that. He ate it. Mom couldn't believe it, so she's here taking out her iPhone. Technology is wonderful, by the way. Takes pictures of everything, the Mio, the yogurt, the granola. The biggest thing that I'm really pushing this year is quinoa. Quinoa is a great grain, high in protein. It's a carb. So I suggest for the mom to make a big pot, put it in the refrigerator. When they do rice, noodles, of course it goes on salads, put some in there because all of a sudden now it's a texture. Quinoa will also pick up the flavor if you do any kind of sauces. It's like a tofu type thing. Very, very healthy. The other thing he tried, which I was very surprised at, is hemp seed. Have any of you tried hemp seed? It's a very nutty flavor, and it is great protein as well, and it's also carbs. And you could add it to the yogurt. You could add it to sugar-free pudding. So there's different things you can do. So for feeding aversions, those are the type of things we do at our center. Infants may not tolerate cornstarch, so typically they're not tolerated less than 6 months of age. due to the lack of pancreatic and intestinal amylase. So around 12 months is when infants typically tend to fully absorb cornstarch. So we try around 6 to 9 months, 1 gram at a time. You increase it every 72 hours by 1 gram if no diarrhea. Very important, if there's no diarrhea. So the advantages of cornstarch therapy overnight. Overnight continuous feeds gives a high insulin state if feeds interrupted. Mechanical problems, leaking. Hypoglycemia develops quick, increased risk for seizure. Versus the cornstarch therapy, low insulin state, doses given every 4 hours. Glucose fluctuations, parental concerns over nighttime feeds, and decreased risk for seizures. So here's an example. There's a 12-month-old that requires approximately 4 grams per hour glucose or 48 grams of glucose over 12 hours overnight. So the overnight continuous feeds of Prosobi is approximately 2 grams of carbs per ounce. So it's 24 ounces are needed, rate of 60 mLs per hour. So it's like 480 calories. So the cornstarch with Prosobi every 4 hours, it's approximately 4.5 grams of carbs per dose. So it's from 15 grams of cornstarch equals 14 grams of carbohydrates. 2 ounces of Prosobi provides 4 grams of carbs. Total of 18 grams of carbohydrates divided over 4 hours equals 284 kilocalories. Look at the calorie differences. You save calories. For children, cornstarch boluses are usually done around the clock. Estimating nutritional needs, we usually majority of the time actually go by ideal body weight. The dietary fat is around the 20% calories. High triglycerides and cholesterol indicative of poor control. Carbohydrates is around the 60-65% total calories. Cornstarch is usually around 30 to 45%. Protein we use as the recommended dietary allowances, or as we also know it as the DRIs. Vitamins and mineral deficiencies, common with type 1 due to dietary restrictions of major food groups. Common deficiencies is your calcium, your zinc, your vitamin B, C, and D. Daily multiple vitamins with iron is highly recommended, and altered iron absorption is in type 1. Nutritional deficiencies in type 1, not uncommon to have iron deficiency. Calcium and vitamin D supplementation. Calcium citrate, vitamin D deficiency is very common. At UF, we aim for 25 hydroxy vitamin D levels need to be at least above 30. Routinely checked annually. So how much fructose is allowed? Less than the 2.5 grams of fructose per meal is our recommendation. So everyone knows that sucrose, you heard me in an earlier slide, I said 5 grams. We know sucrose is broken down in your body. Half goes into fructose and the other half is absorbed. So that's how we get the 2.5. Half of 5 is 2.5. So let's have some fun. Which food has more sugars? An egg bagel or an avocado? Remember, an avocado is also a fruit. Actually, it's the egg bagel. Amazing. We also use a program that's called NDSR, and every one of my patients does a 3-day food diary. And I actually put in, and it breaks down every single vitamin, mineral, and all the macronutrients for them. And when I did that, and I always show the parents that, because what's always been pushed for our type 1? Rice, pasta, bread. Am I right? To keep the carbs. But what I like about vegetables and on the avocado, we know it's a healthy fat, plus the fructose is very low. So which food has more sugars? The carrots. So when we talk with a lot of our patients, if someone's not under good metabolic control, we totally really ask them to restrict fructose. But if someone's under great metabolic control and they start becoming a teenager, they start going to dances. What do they serve? Fruits, cheeses, and what should they not be eating? So what I try to do and accomplish as a dietitian is for them to understand it's okay for them to have 1 or 2 strawberries. It's okay for them to have a bite of cheese. I don't want them to eat a whole cup of strawberries. But you know what? They don't want a whole cup anyway. Just by allowing them to have 1 bite, I've seen them take a bite and put it down, and that satisfied them. So again, it's up to how you want to speak with your patients. So what is a simple sugar? It is the same as simple sugars, which include candy, fruits, and desserts. And it's the fruits that I think they have the hardest with. So what is a complex carb? And forgive me, because I know every one of you know this better than I do, but remember, this is what I kind of cover with my parents. Of course, rice, noodles, pasta, bread, cereal. And actually, I reviewed at least 15 different articles, and this is exactly what they say a complex carb is. And in my dismay, I felt, as a dietitian, so are vegetables. Read those articles. I believe I just saw one that mentioned vegetables. Everyone missed it. The nutrients that our children would get from homemade vegetables or wherever, the fiber is amazing. I would say 90% of the food diaries, that is missing. So when I first start to speak with new patients, especially infants, I want them to bring vegetables in very early. Sugar alcohols, encouraged to intake among patients to increase variety in diet. And now I do have some patients that will say, I don't want my child to have any artificial sweeteners, which is fine, but that's very few and far between. I have parents are more concerned about their children to be like all the other children, so they want to be able to drink different things just like the other children. So we tell them which ones they can have. Of course, sugar alcohols with the GI distress, I tell them to beware. And these are the ones that are allowed. Sorbitol turns into fructose into your body, so we ask them to limit that, or actually not even use it. So what I have done is parents say, well, I can't remember all these sugars they're allowed not to have. And actually, one of the members in our team said, Kathy, can't you make up something for them to remember? So I go, what should I make? Well, something like a business card that they could put in their wallet. So I did, and parents love it. Green is go, the sugars they can have. Red is stop, sugars they cannot have. So when they're going grocery shopping and reading labels, at least they have something right there. Or if they go to an aunt's house or a grandparent's house, they're not going to remember. Artificial sweeteners, Equal, Sweet and Low, Splenda, Stevia. There is a new one I'm sure you guys might have seen. I know in the U.S. it's Nectris, and it's made from monk fruit. I've had several calls on that. We don't recommend it since it's from a fruit. We don't know how it affects blood sugars yet. So we do not recommend it. The other thing I have is as they become young teenagers and young adults, they get very concerned about their weight. Well, the one place they cannot cut is cornstarch. We all know that. So what do they need to do? Portion control. Again, when parents are serving the children and their their teenagers, they put the same amount as they eat. Carbs in, energy in, nothing's going out, you're going to expand, right? Lack of exercise. I even watch them when we have a tendency to, we actually do. The first time we meet someone, we'll have them in for 2 nights. If someone that comes in and has been with us, it's just like a follow-up, they stay 1 night. I watch the children. The ones that are more overweight don't get out of bed. There's nothing wrong with them. They could be still playing or doing whatever. They're doing video games or watching TV. So when I go in and speak with them, I kind of make a deal with them. I ask them, how much video time do you have or TV time? And the parents look at me, a lot. Okay, so this is my deal. For every half hour that you do computer games or watching TV, you need to do some jumping jacks. Make sure I want you to be aware of your blood sugar, how you feel, but I need you off that couch. Parents are actually doing it. When they hear it, they don't realize that what the kids are doing at home, but when they hear it from us, they try to listen. And the kids actually have fun. I would ask them, can you do 10 jumping jacks for me? And they would say, mm-hmm. I go, can you show me how you do it? Do you know how excited they are about getting out of that bed and doing it? And I told the parents, this is what I'm asking you to do. And they said, okay, we'll see how it goes. So here's a case study. 28-year-old female, type 1A, you know what that is. I can't say it. Yes, large liver. Restricting simple sugars, always feeling sick, hospitalized several times a year. She was overweight, was not under good metabolic control with triglycerides over 1,700. Cornstarch administered as 1.75 grams per kilo every 6 hours. Here's the before and here's the after. She came to us at 28. 380 grams, she was grossly over dosed for cornstarch. We ended up, she was spread out 6 hours, we decreased it, less amount, decreased the amount of cornstarch. Patient had moved overnight dose up to get more sleep, so she thought more is better. We all always think more is better, right? Not in type 1. So she saved 160,000 calories per year and all labs normalized just by making it smaller time instead of stretching it. What else do we do for weight management? We have the Crystal Light, the meal liquids. We also recommend the almond milk and soy milk. And those are the things also we recommend with the cornstarch. People forget about water. To lose weight, you need to drink water. Flush your system. For type 1B, nutritional management of type 1B and 1A are same. Neutropenia, IBD, immune dysfunction. IBD typically presents in the second decade. Probiotics, changes in the microflora caused by cornstarch. Neutropenia, frequent antibiotic therapy. And may be useful in children that do not tolerate cornstarch. I know I was supposed to cover type 1. I know Anne's covering type 3. I just want to touch the nutrition pieces that we do for 6 and 9 just really quick. And this was already covered earlier. So the goals of nutritional management for type 6 and 9, prevent hypoglycemia, normalize plasma glucose concentrations, minimize ketosis. So we do frequent small meals, cornstarch, 1 dose in babies at 9 time, 2 to 3 doses if more active. Bedtime cornstarch doses prevent ketosis, improves energy. We do the high protein diet, the 2 to 3 grams per kilo per day. Not as high as type 3, not trying to prevent muscle breakdown. Complex carbs, and we do try to still limit simple sugars. So during their visit, all patients that visit are asked to submit a 3-day food record, like I mentioned earlier. I do the nutrition software that analyzes foods for breakdown of sugar content. The 3-day average intake of vitamins and minerals, excess caloric and protein intake, and an appropriate dietary education is what I do. So parents that come in often that I'm finally really getting to know them, they think they don't have to do the food diary. I go, your child's growing. Sure enough, one parent didn't do it, and I just asked, well, then just do 1 weekday, 1 weekend when you go home. Send it back to me. The child was deficient in several things, which before the child was not. Remember, they're growing. The hyperlink down there in the U.S., and you can, I'm sure, get it anywhere where you are. If I ask you right now, how many grams of sugar is in a cup of carrots? I'm not sure if anyone could really answer that, but that site does, and it's free. So if anyone comes in and says, well, how do I know? If it doesn't have a label, like your fresh fruits and vegetables do not, go to that link, and it will break down the different types of sugars. So the dietary guidelines for type 1, as we all know, is limit fructose, sucrose, galactose. We use the RDA for protein. 60 to 65% calories from carbs, including cornstarch. And we usually use the ideal body weight to estimate energy needs. And a multivitamin, calcium, and vitamin D supplementation is a must. And of course, if their iron is low, we do the iron. So for type 6 and 9 dietary guidelines we use, high protein diet, 2 to 3 grams per kilo. No restrictions on fructose and galactose, but we do limit simple sugars. This is our end result. Before treatment, after treatment. The top type 1B is the young lady. The young man is the little taller one with his brother. His brother is 3 to 4 years younger than him. This is when we first saw him. Now look at the difference. He grew just by being on the right doses. I would like to thank Dr. David Weinstein, the team, the children, and the parents. They're so important.
All right, so I've taken a little bit of a different approach with my presentation today. I do want to talk on the nutritional management of GSD3, but I kind of want to look back at the literature a little bit, see where we've been, where we've gone, and where we may be going. I may actually leave you with more questions than answers, but we also have this afternoon for some discussion, so we can take it from there. Sometimes you'll hear it referred to as Corey disease. It is an autosomal recessive inheritance with 1 in 100,000 in the U.S., and I find it interesting that we see these numbers for a lot of the different types, and it's like, really? Do we really know? But anyway, it's rare. We'll go with that. 85%, as was said earlier, is type 3A, and the others are type 3B. And the enzyme, the deficient enzyme, is the debrancher enzyme, and prevents the breakdown of glycogen beyond those branch points. So the first part of breaking down the glycogen works okay, but you get to those the branch chains, and you can't go beyond that. So you end up with these awful shaped glycogen structures in the liver, and that's a problem. Muscle too. Buildup of, as I say here, buildup of abnormal glycogen in both liver and muscle for type 3A, and as we've said, type 3B is only in the liver. Hypoglycemia and myopathy, skeletal and cardiac, are the main symptoms for type 3A. So again, the main problem that you're going to see in a younger child will be hypoglycemia, and it may actually present a lot like type 1. And I think that's the first point where we need to be careful. While we treat similarly to type 1, we also treat very differently. So, and we'll come to more of that later. You may also see the very enlarged liver, which typically is going to improve when they're older. They may have poor growth initially. They may have hyperlipidemia. Hypotonia in young child. Later, that is more of a myopathy, some with the severe cardiomyopathy. Low alanine and low lactate, which we looked at earlier as far as the biochemistry behind the disease. Liver enzymes may fluctuate, but usually, or maybe always, I don't know, usually elevated, but you will see these fluctuations and you're kind of not sure what's causing what. And then 3B, only thought to be liver involvement, although we did have one patient who had some muscle issues later in life. So who knows what will come from that. They are not thought to have muscle involvement. Okay, so this is where I delve back into the older literature and kind of move forward with it. This first article, Dr. Alfred Slonim did a lot of work in this area and has contributed a lot to the way we treat the disease today. So this one, reversal of debrancher deficiency myopathy by the use of high protein nutrition. This looked at one patient. This was in 1982. So one patient diagnosed at 3 months was treated and followed with slow but steady progress. So, often we look at them, we've got their glucose under control. We think things are just going along so nicely. By 5 years of age, he showed that muscle weakness that we've heard about, and he began to have more hypoglycemia. At 7 years, they referred him to Vanderbilt for further studies, and this is kind of his pre-admission diet and then what they put him on over a 6-month period. So calories, they kept about the same. The percent of protein, they increased from 18 to 25%. They brought the carbs down from 61 to 50%. The fat, they upped a little bit from 21 to 25%. The child had been on a nighttime tube feeding, which 20% of his calories were coming from the overnight feed, and at first he was on a dextrose solution, and they switched him over to Sustacal, which is just a higher protein formula, and it contributed a little bit more calorie-wise. So this is what they found at the end of that period. There was marked improvement in the overall strength and exercise tolerance. They restored the branched-chain amino acids to normal. They had previously been low, increased his muscle strength and his muscle mass, induced a growth spurt, and apparently provided adequate gluconeogenic substrate to prevent hypoglycemia. So both high carb and high protein were able to prevent hypoglycemia, but high carb was unable to prevent the myopathy and short stature. So the point here being, we really need to look at the amount of carbohydrate and the amount of protein. And later we'll add fat to that. So then this is another study, myopathy and growth failure and debrancher enzyme deficiency, improvement with high protein nocturnal enteral therapy, again by Dr. Slonim. So this time he looked at 7 patients with childhood adolescent onset of myopathy. 4 of the 7 had growth failure. They underwent long-term treatment on high protein enteral feeds overnight and high protein feeds during the day for somewhere between 8 and 42 months. So again, looking at how he made the change, it was 10 to 13% protein increased to about 20 to 25% protein. Again, the carbs were decreased. The fat was about the same. Initially, they were not on overnight tube feedings. They were put on overnight tube feedings using Sustacal or Ensure. And so what they found were in the 4 younger patients, so 4 of the 7 showed marked improvement in growth rate, an increased level of activity, improved muscle function. The 3 older patients didn't do as well, and they note that that was perhaps due to compliance issues. Improvement in muscle function is slow and requires intense long-term compliance. And I put that in red because I think that's one of the things that prevents us from finding out if this different types of diets work. Because if it takes up to 6 months to really see good results, how many patients are going to stick with it if it's not something that's, to their liking especially? So we would need to try to emphasize the importance of giving it long-term trial. In addition, and they ended with this comment that in addition to amino acids, fatty acids and ketones may be beneficial in GSD3. And this will actually come to in another study. So this one came along a little bit later, the reversal of glycogen storage disease type 3A related cardiomyopathy with modification of diet. This was by Dogley. So again, it's just one patient reported here, presented in infancy and treated with a high protein diet, about 20% of the calories, and cornstarch. At 16 years, the child developed severe cardiomyopathy, remained stable on 20 to 25% protein, although there were some compliance issues, 16 years of age. By 22 years of age, they increased the protein to 30%, with a goal being around 3 grams of protein per kilogram. They minimized the cornstarch from 2.95 grams of cornstarch per kilogram given 3 times a day to 1.36 grams per kilogram divided twice a day. And when I first read that, I kind of reread it again because that's a very high dose of cornstarch. But that is what the child was on, or the adult was on at that time. So it seems like overtreatment to me. Anyway, by doing those things, increasing the protein, decreasing the cornstarch, they saw dramatic improvements in the cardiomyopathy. So this demonstrated a diet of 30% protein and avoidance of overtreatment with cornstarch and carbs can stabilize and even reverse cardiomyopathy. Again, it's one patient, but I think it is a good thing to consider. Okay, this study was one from Duke, Glycogen Storage Disease Type 3 Diagnosis and Management Guidelines. I take it back. This was the guidelines that were put out. It was a consensus. And I'm actually going to come back to this in a little bit. But the thing I wanted to point out from the guidelines was these two pieces here. Subtle motor delay in children may be more widespread than previously identified. 80% of children with GSD-3A had average gross motor function less than 25th percentile for age. We used to always, or at least I used to say in my presentations about GSD-3, we didn't usually see these muscle issues until the third decade of life. Well, that's not true if you look. It may not be evident, but you hear about these children, they don't participate in activity, they have to sit out of PE, blah, blah, blah. So this, finally now we have it in print that truly it's been documented. This starts very, very early. If cornstarch not maintaining blood glucose, adding more protein instead of more cornstarch may correct hypoglycemia. And I think some of those other papers agree with this statement. So instead of just pushing cornstarch every time you see their low blood sugar, really try to look at the protein and try that first. Whey protein is recommended if supplements are needed, and therapy varies. And again, I'm going to come back to this at the end of the talk, but for the guidelines, we sort of looked at all the literature, which is variable, and just gave ranges to include everybody. So 20 to 30% protein, 35 to 55% carb, that's pretty wide range, and 20 to 35% fat. So then another study, this one was from Duke, Cardiac Pathology and Glycogen Storage Disease Type 3 in May of 2011. Glycogen accumulation in the conduction system, similar to that seen in Pompe disease, which is GSD type 2, has led to lethal arrhythmia. As previous slides suggest, a high-protein diet is thought to possibly improve muscular and cardiac manifestations. More evidence is needed to confirm this finding. We've had several patients that have passed away. One, I believe, was in her 30s. And I will say she was not the most compliant, but I never would have expected her to have died from the cardiomyopathy. So that's just something to really keep in mind. And again, several people have said it. It's not evident when they're young and you think you've got their blood sugars under control and they're doing well. We really need to think about all the long-term consequences and what can we do to prevent that. And then this one, I won't even attempt to say this doctor's name, but he wrote a paper, Successful Treatment of Severe Cardiomyopathy in GSD Type 3 with DL3 hydroxybutyrate, ketogenic, and high-protein diet. And I really, when I first read this paper, I was really fascinated and interested, and so I wanted to go back and kind of dissect it and see what the diet was, which we'll look at. But this paper is about a 2-month-old infant. She had had a sister with GSD-3 who had died at 11 months with cardiomyopathy on conventional treatment. They initiated experimental therapy using these synthetic ketone bodies. They put her on a 2-to-1 ratio ketogenic diet to reduce her glucose intake, and they put her on a very high-protein diet to enhance gluconeogenesis. So 24 months later, her EKG showed improved cardiomyopathy. Growth and liver size remained normal through that period. Blood glucose levels remained in the normal range, and insulin levels decreased. So the hypothesis here, the diet was 65% lipid, so very high fat, 15% protein, 20% glucose, and the beta-hydroxybutyrate, the synthetic ketones, were 400, and they increased them to 800 milligrams per kilogram per day. So the hypothesis behind this is that by providing an alternative source of energy for the heart in the form of ketones, was able to reduce her cardiomyopathy, and then decreasing glycogen storage disease in the heart by reducing the carbohydrates. So we're giving an alternative source of fuel for the heart and preventing the buildup of glycogen with this particular diet. So, this is a pretty extreme route to take, but I think it does lend us some information of things to think about, and it brings in the whole component of fat and how much lipid, what type of fat, more to think about. So again, more questions than answers. Okay, and then this one, heart failure due to severe hypertrophic cardiomyopathy reversed by low-calorie, high-protein dietary adjustments in a GSD type 3A patient, 2011. I'll read through it first and then we'll comment on it. So this was a 32-year-old female. She had been diagnosed at a young age. At 8 years, she was noted to have hepatomegaly, hypertrophic cardiomyopathy with left ventricular hypertrophy. Her diet was protein-enriched meals and a late-night snack. She did not have hypoglycemia. Her liver size was normal. Her heart remained stable and symptomless. At 25 years, she presented with dyspnea, fatigue, obesity, and worsened cardiomyopathy. So for diet, they increased protein, they added a tube feeding with cornstarch at night, and at 28 years old, her symptoms had worsened and she had gained more weight. So then she was evaluated for a heart transplant at the age of 30. She was put on a 24-hour tube feeding of 900 calories, 37% of the calories from protein, 61% from carbs, and 2% from lipids. So she lost 10 kilograms, of no surprise, after 4 months. She had improved symptoms. So they increased her then to the 1370 calories using high-protein meals and drinks, and they gave her cornstarch twice overnight. So the makeup of the diet was 43% of the calories from protein, 50% from carbs, and 7% from lipid. 3 years later, she remained stable, reasonable exercise tolerance, and minor symptoms of daily life. And when I was going through this last night, I had lots of darts to throw at why they did what they did, but they actually, when I got to the next slide, I realized they had summed it up nicely. So, reversal of extreme left ventricular hypertrophy in GSD3 is not clear from this study. Was it the high protein? Was it the low carbs? Was it the weight loss? Or was it a combination? Well, I think we can probably figure it's some combination of all of the above. So from this, they were recommending a high protein diet of 20 to 30% calories from protein, 4 grams per kilogram in young, and 2 grams per kilogram in an older child. And I was glad to see that they had put it in both percentages and grams per kilogram, because for me in practice, that always became a big issue or question. So I thought that was a helpful piece. And to monitor renal function and regular cardiac function. And this was a paper from Duke that I find interesting, bulbar muscle weakness and fatty lingual infiltration in GSD type 3A. This paper describes bulbar weakness in 3 patients, ages 38, 58, and 52, and it's this lingual weakness with dysphagia. And so the recommendations coming out of this were for routine assessment of speech and swallowing function to include lingual strength testing, and consider quantitative whole-body MRI to include the neck and lingual region, and to detect subclinical disease. So again, we're going back to even a young child. You may never suspect or see this, but it may be evident early before it is actually detected. So just something in our assessments as nutritionists to be sure to touch on, are there any problems with chewing, swallowing, and I'm sure we all hopefully do that, but just to have it in the back of our minds, I think. And it was really neat. I don't have the slides, but to see the slides of these whole body MRIs, and you can really see where that weakness shows up in the body in the patients with GSD-3. And then this paper was on exercise intolerance in GSD-3, weakness or energy deficiency. And I found this one kind of interesting as well. 6 patients were studied, ages 17 to 36. They looked at their exercise capacity, and they looked at giving glucose versus saline. So glucose improved the work capacity, it lowered the heart rate, and it increased peak work rate. This suggests that not just muscle wasting, but exercise-related muscle fatigue. So an insufficient energy production in the muscle. And I'm not quite sure that I had ever given that so much thought. I always thought more myopathy. But let me go ahead and then come back. Yeah. So this led me to start thinking more about, we're leaning towards high protein, low carb, maybe some higher fats. We talked about limiting simple sugars to avoid the glycogen storage. But with this, it makes me think with exercise and when they need quick bursts of energy, or again with illness, high stress, we do need to think about glucose. And I don't know the exact answer of how much, but I think there is the potential for giving glucose to these children when they are exercising. So now I've kind of gone through some of the literature I found interesting, and then I wanted to look more at the nutrition, what's in the literature from a nutritional point of view. I think everybody in this room probably knows this article very well. It's kind of been our go-to for GSD since 1993, and I actually still think it's probably one of our best go-tos for how to treat children with GSD-3 or type 1 as well. This is Teresa Goldberg, the dietitian that worked with Dr. Slonim, who wrote this, and it starts out, it's very controversial how we treat GSD-3. I think that still holds true today. Most agree that high protein is important. We may differ on how much protein. Some recommend high carb with cornstarch. High carb with cornstarch does correct hypoglycemia. I think where we get into the gray area is overtreatment with cornstarch, perhaps. What they found, high protein and low carb needed to treat hepatomegaly, muscle weakness, and growth failure for the long term. Too much carb increased hepatic and muscle glycogen deposition. Abnormal glycogen fragments act as irritants to tissue and interfering with normal cell function. I'm not sure she says it later, but they did not use cornstarch. They tended to just use the high protein, low carb, and were able to get good results that way. So their guidelines suggest that for infants, just to use standard infant formula every 3 hours. And then when they're age appropriate, supplement with high protein strained foods. So starting more with the meats and those types of foods when they're age appropriate. At 1 year, they look at a diet that is composed of 25% calories from protein, 45% from carb, and 30% from fat. So high protein, low carb, moderate fat, normal fat, sort of. Protein-fortified milk, like a whey protein added to milk, may be used if needed. And that's if they need extra calories, if they need to bump up the protein, or if it's a finicky eater and they need some kind of a formula to give the child. Limited concentrated sweets, and that, she says, was more to just make room for all of this high protein. Some, and this is where she said it, some use cornstarch, but they did not use cornstarch for their patients. Tube feeding may be needed overnight, following these same goals as above. So this goes back to the consensus guidelines that were done in 2010, and these really took more of a probably general approach. So for infants and children, small frequent feedings, complex carbs, protein, avoid simple sugars, and avoidance of fasting. And I think that's a perfectly good statement. It doesn't give you a lot of detail to work with, but I think it's a good guideline. Cornstarch therapy, if you're going to try that, can typically, as Kathy alluded to, usually around the first year of life when they have their enzymes to help digest it, can be tried. I did not put in here how much cornstarch. In the guidelines, it does give the example of 1 gram per kilogram as a place to start. I think perhaps you could even start with less than that and work up, just really keeping in mind the protein. Is the protein going to give as good or better results? But certainly to use cornstarch is needed. I used cornstarch. I used as much protein as I could, but I found I needed cornstarch in type 3s. But if I went back and did it again, I might try some different things. Let's see. Bedtime snack, cornstarch, and/or continuous enteral feeds as needed overnight. And then for adolescents and adults, pushing the protein a little bit higher, 25% protein, avoid simple sugars, avoid fasting. Bedtime snack, low-fat milk, protein powder, or high-protein formula by tube overnight if severe myopathy. GSD 3B, really just a regular, well-balanced diet. Their hypoglycemia tends to improve as they get older, so as long as you're able to control their hypoglycemia, otherwise we think they should be okay. So here I've just kind of compared from what Dr. Slonim and Teresa Goldberg had put in their paper versus the consensus guidelines, and they're very similar, I think. 25 to 30% protein, 20 to 30, so we could say maybe around 25, 30 would be a good place to start. The carbs are a little bit different. We tried to include everybody. They've got their 35 to 40. They really push the lower carb. And then the fat around 30%, 20 to 35. So when you're treating children with or adults with GSD-3, obviously we want to do blood glucose monitoring. She mentioned the blood ketone monitoring, which is something we've only begun to do in the last, 5 years or so. Maybe longer, I lose track of time. But I think that's very important. Sometimes we even see normal glucoses, but we'll see those high ketones. And that lets us know there's something stressful happening at that point, and that may be a good time that they need an extra snack or they need some adjustment. Food records. I never got as lucky to get 70%. I don't know. I must not be strict enough. But anyway, I do think they are incredibly helpful if the patient will do them, if they will be honest, and if we have a good analysis program to give them the information back that is important. And as I would tell them, the only way I can make a suggestion for change is if I know where you are and what you're really doing. Anyway, that was a problem for me for a long time. I just couldn't seem to get them to bring me their records. And maybe that's because our patient population was established. We didn't have as many new patients, and they thought they knew everything and didn't need any change. Obviously, growth parameters, how they're growing, checking their liver enzymes, the CK, the lipids, prealbumin. Prealbumin's another interesting one. We didn't always check that in GSD-3. And then when we started checking it, we would find they were low, and that led me to know I could push the protein more. Either they truly weren't taking enough or taking what they told me they were taking, or for whatever reasons their prealbumin was low, so we could go up on that. And then more recently, really in the younger children, is even doing swallow studies, feeding therapy, strength testing, just to pick up on those underlying things that may be starting earlier in life than we realize. So instead of waiting around until they're evident, trying to discover them earlier. And I use the feeding therapist all the time because it's not my strength. And we do have a lot of our patients with feeding issues. So we try to get them set up with the feeding therapist to get over those hurdles. And this was just a quick case study. And I wish that I had time to do a follow-up with this patient since I last saw them. And I was hoping the dietitian that took my place at Duke could be here today, because I was going to see if she could follow up on this, because I think he was in clinic recently. So he was a 2-year-old male when he came to us, and his height was 25 to 50th percentile for age, so pretty normal height. He was a Hispanic child. His weight was well over the 95th percentile for age. He was getting 1.4 grams of cornstarch per kilogram for a 12-hour fast, and that gave him about 1.8 milligrams of glucose per kilogram per minute. He was eating baby food at the age of 2, and he was drinking 20 ounces of milk per day, and he was restricted on his fruit intake. So he was overweight, and partially that was from his hepatomegaly, but also I believed it was from overtreatment. So what we recommended was to decrease the cornstarch at bedtime, and that sort of sounds odd because he was on a low dose of cornstarch, but he was fasting for 12 hours. So we kind of decreased the amount, split it into 2 doses, and had them not fast him as long at night. Again, decrease the length of the nighttime fast. And then we increased the protein by adding whey powder at bedtime, and had Mom begin to advance to table foods. I'm sure we tried to get her into the feeding therapist, but as I recall that transportation was an issue, and getting there was difficult. And we wanted them to add back fruit because in GSD-3 there are no sugar restrictions to speak of. Sample diet that I gave them was 20% protein, which was about 4 grams per kilogram, so I pushed it pretty high, 50% carbs and 30% fat. Again, so I think we sent them home with 1, and then I followed up with them and actually went to this split dose of cornstarch at 9 p.m. and 3 a.m., giving 2 tablespoons of cornstarch and a half a scoop of Ungary protein powder, whey protein powder, and 4 ounces of skim milk at each of those times. There were major compliance issues, and actually the child had come to us from another center who had tried to implement diet as well, and they sort of did their own thing. So that was a big hurdle. The other thing I discovered at some point was that Mom would pre-mix her milk and whey protein and cornstarch, and then give it to him. And we don't recommend doing that just because we don't know what's happening to that cornstarch over time. Is it breaking down and not going to be as helpful? The other thing I discovered was that she was checking blood sugar, but if his blood sugar was low, she didn't really do anything about it, so she didn't rescue him. She would give him some milk with cornstarch in it, but not really a rescue to fully recover. So we reviewed that again. We reviewed the GSD-3 diet again. We talked about protein. We recommended OT and speech for feeding therapy. Okay, so we did do that. And we recommended physical therapy as well. We requested food and blood glucose and blood ketones records. I don't believe that I got them. And he was noted at 2 years old to have the left ventricular hypertrophy. And that was actually where I left off with the patient. I had that last slide, which was on gene therapy. So that's the wave of the future, and hopefully that will solve all of our problems, but we still have a ways to go for that. So in the meantime, we need to come up with the best practice. And I don't know that I've left you with, any answers to that question, but I think there's a lot to consider.